Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive into something absolutely central to, well, frankly, our quality metrics and definitely our patients' functional recovery. Evidence-based wound management.
Exactly. Our mission today is really to take all these, sometimes complex guidelines and reviews and boil them down into high-impact, actionable knowledge for you, our colleagues listening in.
Right. We're not just listing facts.
No, definitely not. We want to get into the why. The clinical rationale behind optimizing healing, minimizing those nasty complications, and importantly, making good decisions about resource use right there in the hospital.
Yeah, and this deep dive feels necessary because, look, it's a complex field, no doubt, but the basic principle is simple, isn't it? Yet it's often not executed well.
That's the frustrating part.
Modern wound care has to be about systematically applying interventions that are actually backed by research. We've really got to move beyond just, well, this is what I've always done. That anecdotal stuff just delays healing.
Especially with high-risk wounds. We're talking surgical site infections, pressure injuries, those really challenging diabetic foot ulcers.
The cost of delayed healing is just huge. For the patient, obviously morbidity, quality of life, it's terrible.
And for the system too, longer stays, more resources, it adds up fast. So the goal has to be consistency, better quality care, all guided by the best evidence we have.
Okay, so let's start right at the bedside, the foundation. Getting the assessment right and controlling the wound environment.
That's it. The core principles boil down to a really solid initial assessment, being aggressive about preventing infection, and this is critical, maintaining the right kind of local environment for healing.
And that environment piece. Let's talk about moisture.
Yes. This is probably the central evidence-based idea, and it's been around for decades, but still needs reinforcing.
Yeah.
You have to maintain a moist wound environment.
It's not just a preference, is it?
Not at all. It's biology. When that wound bed dries out, the cells just stop. Fibroblasts, keratinocytes, the ones doing the building work in the proliferative phase, they literally get stuck within hours if it desiccates.
So our job isn't just picking a dressing. It's picking the right dressing or strategy to create an environment that actively helps, not hinders, stops the wound from becoming like cellular flypaper.
Exactly. A moist environment helps new blood vessels form angiogenesis, and really importantly for the patient, it reduces pain. Pain's often a huge barrier to getting people moving and recovering, right?
Absolutely. Okay, so moving into that systematic assessment, before we even think about dressings, the history is paramount, isn't it?
Totally. You need the details. How did this happen? When did it start? And crucially, what systemic issues is the patient bringing to the table?
Right, that's systemic history. That's where we as hospitals really need to dig in. You've got to identify those comorbidities, poorly controlled diabetes, renal failure, any vascular disease.
Because those conditions mess with microvascular function, they impair the immune system systemically. Healing is going to be delayed, almost guaranteed.
And the medication review, non-negotiable.
Gotta look for those systemic corticosteroids. They just slam the brakes on inflammation. Or other immunosuppressants for autoimmune diseases or transplants, knowing that upfront helps manage expectations.
And tells you maybe you need to be thinking about adjunct therapies sooner rather than later.
Precisely. And in acute care, you absolutely have to check tetanus status, especially with dirty wounds or crush injuries. Simple, but easily missed.
And we need to be super vigilant for certain high-risk situations. Bite wounds, human or animal, or any trauma involving saliva.
Red flag. Immediate thought should be early antibiotics. That mixed oral flora, the anaerobes, the strep species, the infection risk is just inherently high. It can blow up fast into cellulitis or worse.
Okay, so history sets the stage. Then the physical exam needs to be just as systematic, and the documentation has to follow.
First step, classify the wound type. Is this an SSI, a pressure injury, an ischemic ulcer on the leg? The cause dictates the entire treatment plan. It's your roadmap.
And documentation is how we make sure the next person knows what's going on. It can't be vague. It needs specifics.
Precise measurements, length, width, depth, always using the same units.
Yeah.
Describe the exudate. Is it sanguineous purulent? How much is there? And what does the skin around the wound look like? Is it macerated? Red?
And critically, for things like tunneling or undermining, you have to use a clock face reference.
Yes. Tunneling at 7 o'clock, 3 centimeters deep. That's communication. That lets the next clinician actually track if things are getting better or worse.
And of course, the exam is where you spot the real triggers for systemic treatment, those local signs of infection.
Right. Increasing redness, maybe warmth, that telltale foul odor, purulent drainage, or systemic signs like fever, high white count. That's what guides your decision for tissue cultures and starting systemic antibiotics, following IDSA standards, of course.
Okay, let's pivot slightly. Wound cleansing. There seems to be, persistent confusion sometimes about what to use, but the evidence is pretty clear, isn't it?
It is, and reassuringly simple for most cases. For the majority of clean or just mildly contaminated wounds, plain old sterile water or normal saline works great. It's effective, it's not cytotoxic, it doesn't harm healthy cells, so it's really the go-to.
We see people reaching for harsh stuff sometimes.
Yeah, and the goal isn't sterilization. It's mechanical removal of debris without hurting the good tissue. Now, that changes if the wound is heavily contaminated. Then you need more force.
High-pressure irrigation.
Exactly, that's beneficial there. Usually with a syringe and, say, an 18-gauge angiocath or a specialized device. You're aiming for about 7 to 8 psi to really flush things out.
But what about adding antiseptics to the irrigation? That comes up a lot. Where do they fit in?
It's a debated area, definitely. Generally, things like polyhexanide, silver nitrate, acetic acid, povidone iodine. They should probably be reserved for irrigation in wounds that are clinically infected or really complex with a very high bioburden.
Because of the cytotoxicity risk.
That's the main concern. They can harm the new cells you're trying to grow. The place where there's clearer evidence is using them intermittently during negative pressure wound therapy with instillation. NPWT-ID.
Right, the instillation and veil cycles.
Yeah, that provides a kind of hydromechanical cleaning and helps disrupt biofilm. But for routine irrigation of non-infected wounds, stick with saline or water.
Okay. Now, classification systems. These are so important for talking to each other and predicting outcomes, right? We need a common language.
Absolutely essential. For surgical site infections, SSIs, we use the IDSA definitions. It's all about depth. Superficial incisional, just skin and subcutaneous tissue. Deep incisional involves fascia and muscle, or organ space, deeper structures manipulated during surgery.
And that links directly to the CDC NHSN surgical wound class, doesn't it?
It does. That system, clean, contaminated, and dirty infected, is highly prognostic. It helps predict complications, readmissions. A dirty infected classification, existing infection or perforated viscous, immediately flags that patient for higher risk and maybe longer prophylactic antibiotics.
Then you get to lower extremity ulcers. This is where good classification is critical for limb salvage.
Right. And the older Wagner system, which just looked at depth and gangrene, it's really not sufficient anymore. It misses key factors.
Like ischemia and infection severity.
Exactly. Which is why systems like the University of Texas, the UT system, are better. It combines depth, infection, and ischemia, gives you much better prognostic accuracy.
But for really stratifying amputation risk, the gold standard now seems to be the WIfI system.
Yes, WIfI wound, ischemia, foot infection. Developed by the Society for Vascular Surgery, it grades the severity of all 3 parts. And here's the practical takeaway. If your patient with a diabetic foot ulcer scores high on the ischemia part of WIfI, say a grade 3.
That should trigger an immediate action.
Right. That score dictates an emergent vascular surgery consult. You bypass the routine wound care pathway. The classification has to drive the clinical action, not just sit in the chart.
That's such a critical distinction. Classification driving escalation. What about for trauma?
For open fractures, we use the Gustilo-Anderson wound classification, GAWC. For major soft tissue trauma, the Red Cross wound classification, RCWC. They're vital for guiding surgical management.
The reliability can be an issue.
Studies show inter-observer reliability can be, moderate in the heat of the moment in acute care, which just reminds us that clinical judgment alongside the classification is still key.
Makes sense. Okay, let's shift to the underlying physiology and the barriers to healing.
Right, because understanding why a wound gets stuck is key to getting it unstuck. Healing is normally this orderly process. Hemostasis stops the bleeding, then inflammation cleans things up, then proliferation builds new tissue, and finally, remodeling strengthens it.
And chronic wounds are chronic because they're stuck somewhere in that cascade.
Usually stuck in inflammation, just perpetual, non-resolving inflammation.
And that's where our evidence-based management comes in, trying to nudge the wound along the right phase.
Yeah.
Like maintaining moisture helps cells migrate during proliferation.
Exactly. If you interrupt that process, say by letting it dry out or get infected, the wound basically breaks down and resets back to the inflammatory phase. It's a vicious cycle.
So what are the common culprits? What stalls healing, both systemically and locally?
Locally, infection is the big one. Microbial contamination and especially biofilm that just wreaks havoc. It disrupts inflammation, releases damaging enzymes.
And biofilm is notoriously hard to treat, right? It's like a fortress for bacteria.
It really is. It's a physical and chemical barrier. Bacteria in a biofilm can be up to 1,000 times more resistant to antibiotics and antiseptics than free-floating bacteria.
Which is why just pouring antiseptic on it or giving more IV antibiotics often doesn't work.
Correct. You have to address biofilm mechanically. That means debridement. You have to physically disrupt it.
Okay, what about systemic barriers?
Number one is perfusion and oxygenation. You need oxygen for repair. Fibroblasts, macrophages, they all need it to function. So poor tissue perfusion, whether it's from PAD or the patient is hypovolemic or in shock, that limits oxygen delivery and stalls everything.
We already touched on comorbidities. Diabetes, renal failure, PAD.
They cause widespread microvascular problems, often immune issues too. The body just can't mount a good healing response. You have to manage the underlying condition aggressively alongside the local wound care.
What about general systemic support? Nutrition.
Often overlooked, but absolutely vital. Malnutrition, especially low protein and certain micronutrients, is like a global brake on healing. We see it all the time in frail elderly patients, the critically ill.
And medications again, corticosteroids, shutting down the immune response.
Yep, leaves the wound vulnerable and stalled. And locally, think about the obvious things too. Persistent pressure, that's the definition of a pressure injury. Chronic edema, which compromises blood flow.
The presence of dead tissue necrosis, which is just food for bacteria.
And repeated trauma or friction, all these things promote chronic inflammation and stop progress.
So managing all this requires a structured approach, which brings us to the TIME framework.
Exactly. TIME, tissue management, inflammation and infection control, moisture balance, and edge of wound advancement. It's a really useful, evidence-based roadmap for systematically optimizing that wound bed.
Let's break it down. T, tissue management.
This means getting rid of the bad stuff, the non-viable tissue, whether it's slough or hard eschar. If that dead tissue stays, the wound is just stuck metabolically in inflammation. You can't move forward.
The goal is a clean, healthy bleeding base.
Right. Then, inflammation and infection control. This is a spectrum. You might have overt systemic infection needing IV antibiotics guided by tissue cultures.
Not surface swabs.
Definitely not surface swabs.
No.
Or you might have local critical colonization or biofilm, which needs topical agents, and, crucially, that mechanical disruption we talked about, debridement. We have to be good stewards with systemic antibiotics, using them only for true clinical infection.
Okay. M, moisture balance.
This is where dressing selection comes in actively. You're trying to hit that sweet spot, prevent drying out, and prevent the surrounding skin from getting soggy and breaking down, which is maceration.
Too dry, cells stop. Too wet, the wound gets bigger.
Precisely. It's all about matching the dressing's properties to the amount of exudate the wound is producing.
And finally, E, edge of wound advancement. What's that about?
If the wound healing stalls, the epithelial cells stop migrating in from the edges. Sometimes the edges even roll inwards. That's called epiboly, or maybe there's just too much tension.
So you have to address the edge itself.
Yes. This might mean debriding that rolled hyperproliferative edge, or maybe applying advanced therapies, biologicals, to kickstart cell activity and migration again.
Makes sense. That framework really helps organize the approach. Okay, let's dive deeper into debridement. You've mentioned it's critical.
It's not just critical, it's often the cornerstone, especially for that T in TIME. Getting rid of necrotic tissue, biofilm, those old senescent cells. It's the necessary physical step to allow the wound to actually enter the proliferative or building phase.
And when we talk about the most effective way to do that.
Surgical or sharp debridement is still the gold standard. It's the fastest, most efficient way. It's indicated when you have extensive necrosis, deep infection, or significant established biofilm.
And here's a key point for practice. Sharp debridement is the only method that has really robust, proven efficacy in clinical trials for chronic wounds.
That's a powerful statement.
It is. We're talking about actually cutting away the non-viable tissue until you see healthy bleeding tissue, and often actively taking off those rolled hyperproliferative edges that physically block cells from migrating across.
But it's not for every situation, right? There are contraindications.
Absolutely. You have to be cautious, especially if the blood supply is poor. You never debride dry, stable eschar on an ischemic foot until you know revascularization is planned or achieved.
Big risk of making things much worse.
Huge risk. And obviously, bleeding disorders are a concern, and it takes real skill and training to do it properly and safely.
Now, for us as hospitalists, we might not be taking patients to the OR for sharp debridement routinely, But there's still a role for bedside maintenance, isn't there?
Yes, absolutely. We need to distinguish formal surgical debridement from what we might call maintenance debridement. We can use simpler tools at the bedside, maybe a curette to gently remove slough, or a silver nitrate stick for hypergranulation tissue.
That seems crucial to keep things moving between bigger interventions.
It is. It prevents the wound from stalling out again, especially given the evidence on frequency. But let's touch on other modalities first. What about enzymatic debridement?
Enzymatic agents, like collagenase, work by selectively digesting the necrotic stuff. Systematic reviews suggest they can be better than just relying on autolytic debridement for reducing wound size, especially in more severe wounds because you're adding a specific enzymatic punch.
And autolytic. That's using the body's own enzymes.
Right. It's slower but gentler. You use moisture-retentive dressings, hydrogels, hydrocolloids, to create that moist environment, which lets the body's own enzymes break down the dead tissue. It's great for non-infected wounds where you have time, and it's usually less painful.
Okay, now the one we need to actively discourage, mechanical debridement, specifically wet to dry dressings.
Yes. Please, this should be considered historical practice. The evidence is overwhelming. They're non-selective. They rip out healthy granulation tissue along with the dead stuff.
And they hurt.
Terribly painful when you remove them. We just have so many better, more selective options now. There's really no good reason to use wet to dry anymore.
Good to emphasize. What about as an adjunct? You mentioned NPWT with instillation earlier.
Yes, NPWT-ID. The evidence is growing here. Combining negative pressure with that intermittent antiseptic irrigation gives you aggressive cleaning, helps stimulate granulation tissue, and might even reduce how often you need formal surgical debridement. It can speed things up.
Okay, tying this back to the T and TIME and frequency. You said frequency matters.
Hugely. The evidence strongly supports frequent debridement, especially for things like diabetic foot ulcers. We're talking intervals of 7 days or less.
Wow, it's frequent.
It is. But that frequency, particularly when you combine it with advanced therapies later on, is associated with significantly better healing rates and, importantly, a lower risk of amputation.
Okay, but let's talk reality. Achieving debridement every 7 days in a busy hospital setting, especially without a dedicated wound team or easy OR access, that's tough logistically.
It is a major hurdle, no question.
So how do we, as hospitalists, advocate for that? How do we push the system to prioritize this frequency if the evidence says it's necessary?
It really requires standardized protocols and thinking as an integrated team. We have to make the case that the cost of a stalled wound, longer stay, complications, potential amputation far outweighs the effort of arranging more frequent debridement.
Maybe leveraging trained wound nurses or APPs.
Exactly. Advanced practice nurses, physician assistants, or physicians comfortable with bedside maintenance debridement can bridge that gap between the major surgical procedures. Consistent debridement basically keeps hitting the reset button on the wound, keeping it ready to heal.
Okay, that makes sense. Let's move into local care specifics, dressings, and infection control.
So the guiding philosophy for dressings, again, is maintaining that moist environment. That's the non-negotiable constant.
But beyond that, is there one magic dressing?
You know, evidence reviews consistently say no. For most common chronic wounds, no single type of dressing has been proven universally superior to others.
So selection becomes more individualized.
Highly individualized. You have to balance the wound-specific needs, how much exudate, how deep is there infection, with practical things like cost, what's actually on formulary, how often can dressings be changed, and what can the patient tolerate.
Makes sense. So the main driver is often exudate level.
That's usually the starting point. For dry wounds or minimally exudative ones, you need something that donates or holds moisture. That's your hydrogels and hydrocolloids. They help kickstart autolysis and keep the cells happy.
And for wounds that are really weeping.
Then you need absorption capacity to prevent that awful peri-wound maceration. That's where you reach for foams, alginates, which can absorb many times their weight in hydrofibers. Preventing maceration is just as vital as preventing desiccation.
What about antimicrobial dressings? Silver, iodine, honey, PHMB, where do they fit?
They are powerful tools, yes, but need to be used judiciously. Think of them for short-term management of wounds that are critically colonized, meaning the bacteria level is high enough to impair healing, but not yet a full-blown invasive infection.
And short-term is the key phrase there.
Absolutely critical for stewardship. We're generally talking a defined period, maybe 7 to 14 days max. Then reassess.
Why not longer?
2 main reasons. 1, cytotoxicity. Some agents, especially heavy metals like silver, can actually start harming the new fibroblasts and keratinocytes if used too long. 2, resistance risk. While maybe lower than with systemic antibiotics, there's still a concern about promoting resistance with prolonged topical use. You need an exit strategy.
Okay, that's crucial. This flows right into the broader infection control strategy.
Right. And again, adhering to IDSA principles. Systemic antibiotics are only for clinically infected wounds. Signs and symptoms increasing size, pain, redness spreading, purulence, systemic symptoms.
We guide that therapy with tissue cultures, right?
Yeah.
Deep tissue, not surface swabs.
Correct. Cannot emphasize that enough. Surface swabs just tell you what's colonizing, which is basically all open wounds. Colonization does not equal infection. Clinical signs of tissue invasion are the trigger for systemic treatment.
What about preventing surgical site infections in the first place?
Prevention relies on evidence-based bundles. That means appropriate pre-op antibiotic prophylaxis, timed correctly, strict glucose control, especially post-op, and often things like intraoperative antiseptic wound lavage povidone iodine is commonly used there.
Is there a role for prophylactic NPWT?
Growing evidence suggests yes, particularly on high-risk closed surgical incisions. So not for an open wound, but to prevent dehiscence or infection in patients with major risk factors, obesity, diabetes, smokers, or enclosures under high tension.
Interesting. And the basics still apply.
Always. Strict hand hygiene. It's the absolute bedrock of preventing cross-contamination. And for patients with known MRSA or other MDROs, contact precautions, gown, and gloves are essential to stop spread in the hospital.
Okay, let's broaden the lens again. Moving from local care to systemic support and some of the more advanced therapies. Nutrition comes up again.
It has to. It's often the weakest link, honestly. A significant chronic wound creates a massive metabolic demand, and you simply cannot heal if the nutritional building blocks aren't there.
So we need to be screening patients.
Systematically. Every patient at high-risk elderly, malnourished appearance, chronic illness, large pressure injuries should be screened. Use validated tools like the SGA or the MUST tool. Labs like albumin and prealbumin can help, but you have to interpret them cautiously in acute illness because they're negative acute phase reactants.
And the demands are significant.
Huge. Calorie needs to go up maybe 25 to 30 kilocalories game day, but the real focus needs to be on protein.
What protein specifically?
Because protein is what you need to make collagen, for fibroblasts to multiply. It's the literal bricks and mortar of tissue repair. You have to target high protein intake.
How high?
Generally aim for 1.2 to 1.5 grams per kilogram of body weight per day. And for really massive wounds, complex cases, burns, extensive pressure injuries, you might need to go up to 2.0 kg a day.
Getting that much protein into a sick hospital patient with poor appetite, that's not easy.
It's a real challenge. Standard hospital diets often won't cut it. You frequently need to be aggressive with high-protein oral nutrition supplements or adding modular protein powders to tube feeds if they're enterally fed. It requires active intervention.
What about specific micronutrients?
Yes, deficiencies can stall healing. The evidence is strongest for vitamin C and zinc, particularly for pressure ulcers. For diabetic foot ulcers, vitamins A, D, E, and folate B9 seem important. We're not talking mega doses, just ensuring adequacy or correcting clear deficiencies.
Okay, shifting gears slightly within systemic support. Pressure injury prevention. Huge focus for hospitals.
Foundational quality measure. Risk assessment has to happen fast within a couple of hours of admission using a validated tool like the Braden scale. And it needs to be repeated regularly as the patient's condition changes.
What are the key evidence-based interventions for prevention?
Support surfaces are huge. Standard hospital mattresses are often inadequate for at-risk patients. The evidence strongly supports using advanced static mattresses or low air loss dynamic surfaces.
And don't forget the heels.
Absolutely. Specialized heel protection devices, boots or pads that offload the heel completely are critical. And then there's repositioning.
How often?
Needs to be individualized based on risk. But for critically ill, high-risk patients, the standard is often every 2 hours, around the clock. It's labor-intensive but necessary.
And bundles seem to be key here too.
Yes, the data clearly shows that multi-component prevention bundles combining risk assessment, the right support surface, good skincare, nutrition, mobilization, education are more effective than just doing one thing in isolation.
All right, now what about when standard care isn't enough.
Mm-hmm.
When do we escalate to advanced therapies?
There needs to be a threshold. If standard care, including good debridement and moisture balance, isn't working, you need to pivot. A common benchmark is failure to see a 30 to 50% reduction in wound size within about 4 weeks.
If you hit that wall, you assume something else is needed.
You have to assume there are underlying barriers, maybe biofilm, poor perfusion, cellular exhaustion that standard care isn't addressing. Time to escalate.
And the most robust advanced therapy seems to be NPWT, negative pressure wound therapy.
Yes, the evidence for NPWT, or vacuum-assisted closure, VAC, is very strong for many complex wounds. Diabetic foot ulcers, venous ulcers, complex post-op wounds. Meta-analyses show it significantly boosts healing rates.
I think the odds ratio for DFU was cited as 3.6.
That's right. Compared to conventional care, it works by removing exudate, reducing edema, providing mechanical stress to stimulate granulation, and drawing the wound edges together.
But it's resource intensive.
It is. It involves the cost of the machine and consumables, nursing time for dressing changes, training. It's a commitment. But the outcomes often justify it, especially if it prevents amputation or prolonged hospitalization.
What else is in the advanced toolkit? Biologicals.
Yes, therapies that directly target the cellular environment. This includes growth factors, bicaplamine, PDGF is one example, and various bioengineered skin substitutes.
Things like placenta-derived products, cellular matrices, living skin equivalents.
Exactly. These are designed to provide a scaffold, deliver growth factors, or introduce viable cells to kickstart healing when the wound's own machinery is just exhausted.
Resource intensive again, I imagine.
Very. But again, for non-healing wounds like diabetic foot ulcers, the data shows they improve closure rates significantly. That relative risk of 1.58 you mentioned earlier for skin equivalents, it's a cost-benefit calculation. High upfront costs versus the cost of a chronic wound or amputation.
And lastly, oxygen therapy.
Topical oxygen therapies have shown some promise, improving healing rates in some studies, likely by addressing local tissue hypoxia right at the wound surface. Hyperbaric oxygen, breathing 100% oxygen in a pressurized chamber, is more involved.
Reserved for specific cases.
Generally, yes. Severe diabetic foot ulcers with associated osteomyelitis, certain ischemic wounds, maybe chronic refractory osteomyelitis. It needs careful patient selection, usually guided by vascular assessment, to ensure there's adequate blood flow to actually deliver the oxygen.
Okay, so that covers a lot of ground. Bringing it all together, the theme seems to be complexity requiring coordination.
Absolutely. The evidence is just crystal clear on this. You cannot optimally manage complex wounds, especially in patients with multiple comorbidities, in a silo. It demands an integrated interdisciplinary team.
So physicians, nurses, especially wound-certified nurses, dietitians, PTOT, pharmacists.
And crucially, early involvement of specialists when needed. Vascular surgery for ischemia, plastic surgery for complex reconstruction, infectious disease for challenging infections, podiatry for foot issues.
And that team needs to work together using common protocols like TIME, do irregular joint assessments.
That's the model. And the outcome data is incredibly compelling. Studies consistently show that dedicated multidisciplinary wound care teams, MDWCs, lead to faster healing, higher closure rates, and this is the big one. They can reduce major amputation rates by over 50%.
Over 50% reduction in amputations. That's massive.
It's huge. That kind of team-based approach really should be the standard of care everywhere for complex wounds.
Which leads us nicely into our final thought for you, the listener, to chew on. We've established that for most standard chronic wounds, the evidence doesn't strongly favor one specific dressing type over another as long as moisture balance is maintained.
Right. But we also have incredibly strong data supporting more intensive interventions, especially frequent, consistent debridement and advanced therapies like NPWT or biologicals for those wounds that just aren't healing with standard care.
So the challenge for us working in hospital medicine and for the systems we work in is really about resource allocation, isn't it?
It is. How do we shift resources, time, staffing, money away from maybe just repeatedly applying standard dressings that aren't achieving much towards ensuring that critical, frequent debridement actually happens, that 7-day interval goal?
And making sure that we apply those proven advanced therapies early enough in patients who aren't responding rather than waiting weeks and weeks.
Exactly. If that 4-week mark with less than 30–50% healing is our usual trigger to escalate, maybe that's too late for some. We need better ways to predict who needs help sooner.
So the provocative question we want to leave you with is this. Beyond just measuring size reduction, what other metrics, maybe functional measures, maybe biological markers from the wound fluid, maybe specific systemic indicators could help us better predict, perhaps even at the 2-week mark, which patients are on a trajectory to fail standard care and require that resource-intensive escalation earlier.
Finding those earlier predictors could be key to maximizing limb salvage, cutting down length of stay, and fundamentally improving quality of life for these patients. That feels like the real cutting edge of translating evidence into practice for complex wound care.